right, so we'll just kind of jump into it. I'm not going to spend too much time talking about what we do at Alexander's this year, so we'll just jump into what we did. So we are going to talk about building your process and what that looks like. I know a lot of people are just starting with the application and all of its potential and what you're going to do with it, but I don't know if you guys feel this way, but I did. Just what am I going to do? There's so much everybody wants done. I've got finance coming at me. I've got our performance improvement department wanting stuff. You know, we got state requirements. We've got licensure issues and accreditation requirements. At the same time, we want to do good clinical work. We want to make sure that our EHR is just not a compliance thing. So it needs to actually tell the story. And we want it so that our end users will actually use the application and not go home grumpy at night because there's just so much stuff they're having to do. So that's kind of, you know, what my life is like on a daily basis, trying to figure out how I'm going to maneuver all of that stuff. So we actually came up with an approach that we use at Alexander's, and so that's what I'm going to highlight today. Our approach, I'm going to take us through what we did, take us through a big process from, you know, brainstorming to the end result and how that looked. So at Alexander's, what we did was our approach was to gather a list of, you know, everything we wanted. We wanted it to be a wish list. So we had all of our behavioral health staff, all of our clinicians, everybody just send in all of their lists. Then we had senior management give us their information. Performance improvement, give me all theirs. So we had, as you can imagine, a really long spreadsheet of what people wanted. I think there was about 200 lines of things that everybody wanted on there. After we got all that list together, we then took a look at all of that information, decided how can we combine some of these things into single projects, because some of the concepts are the same. It's just, you know, everybody had a different take on how they wanted to do it. So we then combined it, made it a little bit shorter, which was nice. After we did that, we determined what kind of project was this? Is this focusing on medical? Is it focusing on behavioral health? Is it focusing on a support department process that we need to enhance and stuff? So we wanted to figure out what the category was. And then we identified what kind of action we needed to take. As you can imagine, some of the things that are on our list is not all building in CDT. It's just taking what CDT already has and enhancing it, or making it pop, making it do something for our staff, making it so they can get through it easier. And so we wanted to figure out, is this a development request? Is this a trigger, a store procedure? Is this just a repurposing of a field? That type of stuff. So once we got, you know, those first 3 items done, we then went and rated every single thing on that spreadsheet. So we wanted to figure out the number of staff impacted. With that, the scores are always 1, 2, 3, 3 being the highest number of staff impacted, or affected, and then 1 being very few staff would be affected by this change or this project. Financial risk, as you can imagine, that's huge, so we want to figure out what's the financial risk associated with this request. And so every item had to be ranked according to those, and then the ease of development or the implementation of the project. So we ranked all those, tallied up the scores, took our spreadsheet, resorted according to the highest score. And just because you have the highest score doesn't mean you're a priority, because the highest score could be the highest financial impact, could be the highest number of staff affected, it could be the easiest to develop. But if it is has a dependency on another table that's number 20 on the list, we had to take a look at the dependencies for each of the projects. And so if something was really high, then your dependency, which is now number 20, moves up to number 1, because you can't accomplish number 2 without number 1. And so we did a lot of readjusting and manually looking at some of that stuff and updating our spreadsheet with projects. Then we started to work down the list. So, and just so you know, we still are not done the list. It kind of is an active document that keeps growing every time we look at it. Here's just a quick little overview of how we structured that whole spreadsheet, and it all tallies and everything. So I just thought it would be neat to see how it was structured and put together. So I think we did the list back in 2011, maybe 2010. I'm looking at Scott, I think that's when it was. So prior to us actually starting down the road of the development in 2011, we were using CDT only to capture demographic information. So we were putting in the client profile information. We were capturing activities, but our staff weren't actually entering the activities. They were doing timesheets on all the kids, sending those timesheets to the billing department, who was entering in all of those billable activities and then processing the services. We did have, the only clinical we did have in the system was at the time what we called our authorization request. So our clinicians, when an authorization was coming due, would go into this one screen, which was just a big text, a whole bunch of text boxes, and they type in how the kid was doing to justify the next authorization for services. And we actually put that in place, I think, back in 2005, because we experienced some huge, and when I say like I think it was 1 million or pretty close to $1 million write-off because of missed authorizations. So that was a project we put in place back in 2005. So that's all we had in CDT that was clinical, really. Everything else was more demographic or clerical. Of course, you can imagine that our management team wanted more performance indicators. They wanted to see real-time data. They wanted us to be able to view and know what the client's story was just by going to one place without having to look in your file share or having to look in your paper record or having to go to our document management system to pull up something that we scanned and put in there. Our progress notes at the time were captured in a completely different system that did not integrate with clinicians. So you can imagine that our staff would write the progress note. They would send a piece of paper to billing, but the two systems were not syncing, and so we had some issues. We actually had some write-offs or some, paybacks because we overbilled or underbilled or did some funny stuff where what we billed did not match what we actually said we delivered. And our client service plans and all assessments were done on paper. So, they were done on paper and they'd be in a physical record somewhere, and so not everybody could see it. And our agency actually has about 13 different locations across North Carolina. So if your kid is in multiple programs by different locations, they don't have access to that Word document. So that was a challenge for us. So we decided to re-implement. We actually pulled together a team and we called ourselves the Echo Go Live team, and that was fun. We couldn't come up with a more creative name for ourselves, so that's what we used. At the time when we first started, it was just senior management and myself on the team. We've since redefined the team, and so now we have senior management representation, we've got performance improvement, we've got our clinical director, we have nursing staff, and we have some program staff on the team now and medical record staff. So people from different areas of the organization. We used our approach. Again, we came up with a really long list of things that we needed to do, and then we prioritized our projects. So I'm going to kind of just talk you through one of our visions. You can imagine that huge list of 200 items. I think it came down to probably about 100 different things that we were doing, and different people could do different things, because some of it was crystal reports on the list, some of it was repurposing fields. We handled all that, but we had this big vision that we wanted, we wanted everything to be efficient. We wanted it to be easy for our clinicians. We wanted things that were already in the system to feed other things that are in the system, so we weren't having to, do it more than once or have people spend time reading progress notes to aggregate data. The system would do that for us at the end of treatment. So we started out our project with the person-centered plan, which in North Carolina, our state requires us to use we're required to use this person-centered plan. I wouldn't say it's a great plan, but it's a plan, and so we have to use their format. And so we worked with ECHO actually to develop the North Carolina person-centered plan. And we started that in the summer of 2011, and we implemented it in January of 2012, and we had 400 PCPs that needed to be entered into the system. We recognized that we needed it in fast, and we couldn't wait for the staff to roll it in when they had time. So we hired 10 temps. They came in, took 3 weeks, put in all of our person-centered plans from the paper version into CDT. We were good to go. That was done in January. And then in February, one of our other projects we were working on was the progress notes. The progress notes were actually dependent on the PCP, so we had to do the PCP first, because our vision of our progress notes was we wanted our progress notes to link back to our person-centered plan. Our state requires that you choose a goal on each of the progress notes. That goal has to come from the person-centered plan, and it has to be an active goal at the time that that note was done. So, but we also wanted our progress notes to drive our billing, not right now. We didn't want billing to drive the progress notes. So in other words, we didn't want you going in, entering the activity, then doing the progress notes, saving it, and everything's done. So we designed our progress notes such that you complete the progress note, you tell us what you did, how long you did it, what the status was, and all that stuff inside validated fields in the progress note, and then you hit save, and it updates the activities table, and the billing now exactly matches what's on your progress note. So we implemented a couple programs in February. We implemented a few more, actually the rest by July. Our doctors took a little longer. We had their stuff done. They just didn't adopt to it, or want it so quickly, until we finally said you have to do it, and they went in December of 2013. The impact, our corporate compliance prior to going to the new PCP and the progress notes, we were getting 93% compliance with our progress notes and PCP, and, or the goals on the PCP matching what was on the progress note. In 2013, a year after we implemented it in 2012, we were at 97.5%, which is a huge financial impact for us, especially since our state went to extrapolating dollars. So they would do an audit and then extrapolate. So if you only got 25% compliance, you paid back 75% of everything that you would have built in that time frame. We also had no call-outs because our goals were not matching, well, like the goals on the notes weren't matching the PCP. So that was huge for us because we were having that issue before where people were just writing whatever goal they wanted to on the progress note. Phase 2 of the project, so we had this big plan that we wanted our assessment inside Clinician's Desktop. And that assessment was going under several revisions in North Carolina. What does it need to look like? What information does it need to gather? We were having big changes with our the agencies that were overseeing authorizations or overseeing things, and now we're in a managed care environment where we have our local area programs doing managed care. But clinical comprehensive assessments became required for all basic services, that's outpatient services, and enhanced services. So any service that you deliver where we're actually working with the client, we had to do a clinical comprehensive assessment. So we worked on that, we put it in the system. We had prior to doing the CCA and CDT, our clinicians were taking about 4.5, 5 hours to complete an assessment. It would be 2 hours face-to-face because they would never document at the same time the client was in there. And then they take another 2 to 3 hours to actually do the paperwork because everything was so text intensive, they were typing everything up. So we implemented the CCA in April of 2014. That was a big project, and now our clinicians are taking about 2.5 hours. That it's seeing the clients and doing the documentation because they're doing concurrent documentation at the same time that they're seeing the clients. So we built it because we didn't want them just typing in anything they wanted to type. So now we structure the questions with a lot of check boxes and all that stuff, and when it prints out it looks like a big Word document. So even those check boxes on the screen, it prints out like a 7-page text document. So immediate access to the clinical information. So that's really cool because our clinical director doesn't work at the same site as our clinicians. So she just logs into the system, sees what's going on, and can talk to them real quick about what they need to do, what are some things they should consider, some diagnoses they should consider before they sign off and all that stuff. So, and our recommendations for levels of care have improved. We're not having the issues with our managed care organizations saying you didn't justify this well enough, we're not going to authorize this service. We built in the state recommended level of care criteria into our CCA, and so they have to justify every level of care when they recommend that service. Phase 3, biggest part of getting, delivering services is, of course, getting the kids in and getting them authorized. This was a fun project because it impacted so many different areas, and everybody wanted to give you their feedback on how to do it and how a kid should come into services and stuff like that. And everybody wants it done so fast. They want them into services, they want them authorized real quick. And they want it done right the first time, and they don't want it to deal with anybody else. But the problem is that there's a lot of barriers on the other side, like dealing with the MCOs and what they want to see. So we needed to figure out how we would work that in. So we fixed our process. We aligned our authorization process with the MCOs. So now, instead of doing a clinical justification for a service, we actually went to all of our managed care organizations and pulled the exact information they wanted, built that into our screens, so when you now are justifying the service that you're requested for concurrent authorization, you are putting in what they want to see, not what you want them to see. So we designed our forms to do that. We updated all of our progress notes that we had done and implemented 2 years before. We went and redid all of those and added 9 additional questions to the progress note, which the staff have to answer every time they do a note, that allows us to pull data out and put it on the authorization request form that goes out. No more reading through to figure out how many times did the kid talk back to the people, how many times did he cuss someone out, so it's automatically pulls and aggregates for us. And then we had to improve our steps through, track our steps through the referral process, find out what are the barriers, what are the things that are holding up getting a kid in, and then see if we have some wiggle room to go back to our managed care organizations to say, hey, you're asking us for this information before we admit any kid into the service. Is there any wiggle room on that? Can we not get them in and still get the documentation? So we're kind of working on, we had to identify those barriers so that we could collaborate and work with them on it. After implementing that, we saw a significant decrease in the managed care organizations coming back saying, hey, we need more information. We need to know what's going on. When you said this kid was aggressive, what does that mean? When was the last time they were aggressive? We're not getting that anymore because the information is coming directly from the system, from the progress notes, from the clinical justification and stuff that we're sending. Again, our clinicians are not reading through everything in the system, aggregating on its own, and our program managers understand where the clients are at the point of referral and what information is needed. And that's really cool because I'll show you a little bit later. Every program manager, based off the information we're putting in the system, has a report that they receive in their inbox daily that shows them the kids that are on their waiting list, what's their status, what are we waiting on, because our program managers have relationships with different referral sources in the community, so they can pick up the phone, and sometimes just them helping out with that, picking up the phone, gets us our information quicker. So now we've got our departments working better together. This is my favorite part. It's the final stage in this big vision that we had, which is the discharge process. So before, our discharge summaries were done on paper, so our clinicians would get together or would pull up the Word document, sit and spend 5 or 6 hours typing up this discharge summary, because they would have to go back and read through the whole chart, aggregate some information, figure out how well the kid was doing, did that change over time, what does it look like this last month, all that type of stuff. So that was taking a long time. And then we do when a kid leaves, just like in a hospital, you have to give them a piece of paper, like a discharge form. So we do the same thing, but we found sometimes that information on that piece of paper didn't transfer to the discharge summary. So you might have different recommendations, and so, which is fine, but we want it to capture the ones that we gave them at the point of discharge on the discharge summary as well. So what our vision was is that we were going to create a discharge summary where our staff could just hit a button and everything would come in from that client's treatment. So, the reason why they started the service comes in. So our staff aren't having to type that in. That automatically comes in from the screening or the assessment that was done prior to their admission. We wanted all the aggregate information from how well they did on each of their goals. So in the last 30 days, did they meet their goal, and what was the percentage, how well did they do towards that goal? So what was the percentage of their compliance or with what they were supposed to achieve. We also wanted it so that we could track what was the last information we communicated in the last child and family team. We wanted that to show up on our discharge summary. Any incidents that happened in the last 30 days. We have in our psychiatric residential treatment program some very chronically ill children, and so just because they're discharging from PRTF, they may be going to foster care or day treatment, but there might be still some incidents of physical aggression, restrictive interventions are still being used. We need to make sure that that's tracked, so when that discharge summary goes to the new provider, they see what's happening with the youth and they're not starting over. So we built that all in. We piloted the project with our psychiatric residential treatment program in July, and it was well received, ironically, because that's our program where our clinicians don't adopt computers at all. They hate to see me coming, they hate to see new development coming, and so, but they liked it because they only have, I think they only now have 2 text fields that they have to type in for a discharge summary, and 1 is optional. So they like that they only have to put in 1 quick little summary. Where it's their own personal feedback, things they want to tell people, more that information that you just want to pass on to the next team, but it might not be, aggregated somewhere. So they have that option to type that in. It's much more efficient. They don't have to read back through the notes. And our expectation was that our clinicians complete their discharge summaries within 30 days from the client's discharge from a program. Based off what we're seeing in the number of discharges that we've currently done under the pilot, we're moving that to 14 days, so people are getting the discharge summaries quicker, and so that's cutting down on how much time the next program's having to start over or figure things out. So here's just a quick view of the screen. We created a stored procedure. Our clinicians just kind of go in and indicate what service they're discharging from, because some of our kids are in more than one service. So we want them to indicate what service they're discharging from. All of that stuff validates, pulls from enrollments. They just put it on the screen. And then they hit the import discharge button, and the fields, most of the fields fill in with the information except for a couple. I think there's like 2 fields. 1 is optional, which is this first one on the screen, but the handoff communication is the one that they actually have to fill information in on. Last year I reported I could just run a crystal report, which I could, run a crystal report, create the discharge summary, and we could hand it at the day of admission. But what we found out was we couldn't do that because crystal reports are not editable. And if they are, you export them to Word and you edit it, but you don't have the track of what you edited on a Word document. So we wanted to make sure that everything was inside clinicians' desktops so we could, have that for our own, for the client's actual medical record and stuff. So we had to design the screen, we had to design the store procedure, which does the same thing that the crystal report did, and pull all that information in so that, they could edit it if they wanted to. So some of them don't, but if the information comes in, they have the ability to go into those fields and edit it and still make it their own words, even though most of the information was imported. And to our clinicians, that was significant because they don't like signing off on something that they didn't actually get to touch. So we've changed that a little bit. We have buttons on here, so you can actually click different buttons to get to things that are already filled out in the application. So the treatment history, which is tracked all through the course of their treatment. So some of our kids, at the point of referral, we capture all of their past treatment in this treatment history table. And then when they're with us, if they go somewhere else for treatment, let's say they're hospitalized briefly, we'll put that in there. So we have all of their treatment history tracked in our table. How well they received that treatment, what was the, why did they get that treatment, that type of stuff. So it's all in the table, and at discharge, all you have to do is go verify it. Add some additional information for things that might have happened if it didn't get updated during the course of the treatment. We also have the diagnosis in there, so the clinician can update the diagnosis right from the screen. So they just click a button, pops out the diagnosis, they change it, and it's done. And the medications, they're able to view those as well. So this is a fun one. Plan, do, check, act. We do this a lot. I feel like sometimes some of the screens I build, I'm building them again several times. So, because obviously nothing is perfect the first time we do it, and there's just a lot of changes that go on. So our process is, we want to evaluate the success of each project at different intervals. So we do pilot projects, or pilot implementations with different programs, and we found that has been very beneficial because they give us great information before we roll something out to the whole organization, and then we find out that a piece is not working. So that's worked well for us. It's actually resulted in a lot of changes before we actually implement. We love going to training and we love training the end users, but at the same time, when you train the end users, you get a lot of feedback in that training. So at the end of the training, it's just a big slew of information that they want to see in there. Why didn't we put this? And Jennifer, if you've met Jennifer, she's in our performance improvement department. And what's interesting is she did a training on the CCA when we implemented it. And the clinicians were upset because she took away another document. So they were like, why don't we have to do both? We want to do both. We like doing both. And she's like, you don't need to do both. You only need to do one. So that was an interesting thing for us, seeing, implementing something but having people want to do more. So we thought that was different. We get data regularly, and I'm going to show you some of the data reports as we go through, so you can actually see some of the, from putting all of this information in the system, what we're actually getting back out and sending to our end users, which is very important. And then we have a ticketing system, so everybody sends in tickets to us frequently about issues they might be having or suggestions they will have. And through our team that we still have, so those end users that are on the team, they're actually going out to their programs and gathering information. So when they come to every team meeting, which is every 2 weeks, they're bringing suggestions, and we're throwing those on the implementation list, and some of those get done early because they're quick, and some take a little bit longer, but we're listening to what the end users have to say and trying to roll those in, and then make enhancements. So I wanted to show you some of the enhancements that we've done just with the projects that I've kind of gone over here today. So with the progress notes, all of our progress notes for our enhanced services and our basic service outpatient have been changed to include the 9 extra questions that the managed care organizations want to look at. So that was a big implementation and change for them. One of our PRTF programs, actually just before I came here, made a big suggestion on things that they wanted changed on their progress notes, so we changed that, and they're actually finding it easier to document now with more accuracy. They were having some challenges with trying to tell us whether or not the child met their goal or did not meet their goal, and so they wanted some additional indicators, and so we updated that for them. The CCA, we are now hitting on version 3, which is starting on Thursday of this week. So just stuff that, as you go through it, you find different things that you want to capture, different information you need. Our state also released a new listing of things that should be on a CCA, and so we had to add some of that information. So we're implementing version 3 on Thursday of this week. Our access to services, we updated that whole department's process in February. And it's actually going very well. Our numbers are looking really, really good. Our authorization process, this is fun. We implemented that whole process in February 2014. By February 15th, everybody hated it, the grumbles that we got out, so we reverted back. It failed, and so we have a big old fail on our thing. They didn't like what we put in place, they didn't like how it happened, so we had to redesign it, pull together some more end users, got a whole bunch of additional information, and then we implemented it again in September, and that actually was very successful, and everybody likes it much more, so that's kind of nice. The North Carolina Person-Centered Plan, if anybody in North Carolina has the PCP. We've changed it 3 or 4 times, and we're getting ready to change it again. That one seems to be a document that changes for us very frequently because we're always capturing different things. Or one of our things that we're always doing is whenever somebody comes to the team and says, I want to capture this, I need to capture this, and we're like, okay, well, when do you gather that information? They're like, well, we get it at the Child and Family Team meeting. So now we're going to add it to the PCP because the person-centered plan is updated at the Child and Family Team meeting. So we're always updating our person-centered plan with new things that they want to capture. And our state made us do a whole new crisis plan, so we had to take the old crisis plan off the person-centered plan and add a new comprehensive crisis plan to the person-centered plan. So lots of changes. It was funny when I was going through the timeline, I was thinking everybody's going to be looking at my timeline trying to figure out why I only have 3 or 4 projects up here on the board. Well, they keep changing, and there's other additional projects in there, but these ones have changed a whole lot. So now we're going to look at some data that we actually give out to our programs, and they use them to manage what they're doing. So the first one here is same-day progress note documentation. The expectation at Alexander's for our residential services is documentation has to be done before they leave their shift. And every other service, it has to be done by the end of the day. So this is our PRTF program, and so I've kind of just shown you our supervisors walk in, they run their list, and they can run it for whatever date they want, and they've got a cross tab showing them, you know, do I have a note or do I not have a note for that client for that day? And so if there's no 1 in there, it means there's no note. And I think I ran this just to put up here on the 15th, so the 3rd shift notes haven't been done yet, but they actually, when we implemented the progress notes, we had high turnover because the supervisors start using this, and if the staff weren't complying with the documentation schedule, there was a whole process for, compliance. You got a couple verbals, but then it kind of went a little bit further after that if you weren't going to comply with what's needed. The other good thing about this is that they also, which I didn't put up here because we also have reports which have KPIs, which our supervisors then use for performance evaluations to say, this staff completed their notes within the time frame 80% of the time. So you can see over whatever time frame, let's say it's over the last year, you can actually see what their compliance was. And so each of their performance evaluations has something on there, a line on there that talks about documentation being done in an appropriate time frame. We also have this one, which is a really cool report that we just start pushing out to our managers. And so this comes completely out of the system. Managers are receiving this every morning at 7 o'clock before they start their day. Tells them what their program census is, so how many kids are actually enrolled in their programs. It also lets them know how many kids are pending enrollment. And for our organization, a pending enrollment means they've made it through the whole referral process. We have all of their documentation, we've submitted their authorization, we've received approval that that kid can start services, but they're not enrolled yet. And that's, we see that happen more in some of our community-based services where you can't get a hold of the parents. So we've got the authorization, but now you're trying to get the parents so you can set up that appointment, and it might take a couple days. But we still want our program managers to keep their eye on the ball there because the kids need to get into services, and we just don't want them losing sight of that youth. They can also see their active referrals. This looks prettier on their report. I had to cut out names and stuff, but you can actually see the active referrals and when were they referred on. And then the clinicians can, the program managers can click into that report and actually get detail that says, this client, we have the person-centered plan, but we don't have the birth certificate or, the other documentation that's required to bring them in. So it actually shows them what we're waiting on and what the last communication was with the referral source. Number of clients approaching or exceeding discharge, that kind of helps you plan for the future so that you can adjust and get new referrals in, try and move those quicker so that you're actually meeting your budget for your program. We have a report that lets us know the authorization status, so they get something every day and you can see if the kids are authorized or not that you're serving in your program. What that authorization piece only shows you kids that either don't have an authorization or ready for a renewal so that they know what to address. So there's lots of stuff on there. We have programs like Intensive In-Home where you have to have 12 face-to-face contacts in the first month. So those program managers get a report that shows them any kid that's been enrolled in the last 30 days and where they are in their 12 face-to-face contacts. Shows them if they're in jeopardy of not meeting it, all that type of stuff. So it's really neat. They like using it. Shows them any incidents that occurred so they can actually see what's gone on with that youth, if there's been any restrictive interventions or anything like that. And they see what notes have not been signed so they can get on those staff right away. So it's just a neat little daily metrics type thing that they can see. It also shows them when their North Carolina person-centered plan is up for an annual renewal. So. And we also have, based off the information we have in the system, we have scorecards for each of our programs based off their budget. So whatever's budgeted, set up in the budget for these youth, we can see that we budgeted 36 beds. We're actually hitting at 32, so this program, it turns red because they're not meeting their budgeted number. What's really neat is usage percentage and then actual bed day use. So if I ran this report on the 16th, it's only looking at so it's giving me a projection. So on the 16th, I should be at 426 days, 26 bed days. But I'm only meeting it 91% of the time. So I've got it, it kind of rolls with the days that you put in. So, and then I can see how many clients were in at the beginning of the month, how many discharges there were, and then how many admissions. So I can see I had 36 kids, I discharged 4, but I've only admitted 2, so I'm down 2 kids already in that unit. So that's probably has a big impact on them not meeting their numbers. This is the treatment authorization request form. This looks like what we get in one of our MCO systems. I took out all the client identifying information, but that whole form completes inside one of our reports. Our clinicians, our authorization folks can just print it out or export it, however they want and send it up to the MCO. So they've got the ability to do that for an authorization request. So we've done a lot of type stuff where we're actually mirroring the forms by other people. So if the information's in CDT, we're just taking that information, creating the form and mirroring what other people have. So that way you don't have to sit down and do it on paper. So. Accountability to the process. This is what I was trying to talk about earlier, where you can go in and see the kids that have been referred to your program. I can see that I don't have my CCA yet, which is a required document. I don't have my PCP for this referral, and I don't have my support documentation, which is also required for this program. They require certain, like a certificate of need and stuff like that, so we don't have that, and the authorization has not been received yet. I know who the access staff is working on that case, so I know who to go and contact, and if there is a last note put on it, I can see what they have said to them, what we're waiting on, what are some of the extenuating circumstances. So if I'm a program manager, I'm pulling this up regularly because I don't have a full program yet, and why don't I have a program? So what can I do? Is there anybody I can reach out to get everything? So it also encourages transparency. I don't know if you guys have experienced, you got program staff frustrated with the support staff because they don't know what's going on. This allows that transparency, so now we've got that whole collaboration. Nobody's trying to hide something underneath the rug anymore. It's all right there for everybody. And then just future enhancements. We want to take some information from our CCA and we want it to automatically feed some things to the North Carolina Person-Centered Plan. We just need to figure out how to make that happen so that it fits into how the state wants the North Carolina Person-Centered Plan done. So we are actually in discussions right now of how we're going to do that. We're also looking at changing up the North Carolina Person-Centered Plan because we're trying to make that plan do 2 things to meet everybody's needs, so we're not having to have our clinicians going and doing 2 documents to meet one MCO's needs and another MCO's needs. So we're trying to do it all in one. We are working on a health assessment to be completed directly inside CDT. That will then feed the psychiatric admission assessment that our psychiatrist has to do. So our nurses meet with clients when they come into like psychiatric residential treatment and PRTF. They're going to do the health assessment right inside the system. A lot of that information will then automatically feed to the psychiatric admission assessment. So our doctor is not typing. Everything is already there. When he pulls it up, all he has to do is give us his disposition. And so then we're done. We are in the process of working on integrating a scanning solution and document management system with CDT. So we are speccing that out right now and developing that in. We've got a big project trying to do some foster care matching logic. So we're in the midst of speccing that out. That one's going to be a huge project because, as you can imagine, every foster care home has its own characteristics. Every client has their own behavioral stuff, and then the logic that's going to go behind that's going to be huge. We want to do foster parent supervision and licensure directly inside CDT, see if there's any correlations with kids disrupting foster homes with the supervision issues that are going on in the foster home. And incident reporting, we want it fully done inside clinicians' desktops. So that's restrictive interventions that occur, fully putting all that information in there, and any incident report that occurs. So we've got a lot of different projects going on, a lot of moving and shaking, and then we're also trying to figure out how to do more dashboards and stuff. So we're having fun with a lot of the data. And so this is just a fun little quote that I put up there, but does anybody have any questions? Yes?
When you do the piloting of new processes or forms, do you have people who are doing it the old way at the same time they're trying the new way, or how do you manage that?
If we're piloting, you drop the old way and only do it the new way. So, and we're super responsive. So we've tried to do as much pilot, like I've done as much testing as I can in the test database. I've rolled it in, I've played with the fields, I've done what I think, but I'm not I don't actually work with the kid. I'm not a full clinician and stuff. So we roll it out to the programs. They'll do the discharge summary in the system, and then they'll call me and say, hey, this didn't import. Well, the minute they call me, I'm on the phone fixing the code, and then we have it importing right away. So we're not slowing down. It is slowing it down, but it's not like 3 or 4 weeks. We get it taken care of that day so they can move on.